systemic steroids, and best thing is inhaled bronchodilators, even in asthma or even CO, because you're delivering the drug at the site of requirement. If you give tablet or systemic injections, IV, IM, they take long time, because inhaled steroids, you are delivering the drug at the site of bronchoconstriction directly into the bronchus. That is the advantage, and the quick response and effective response will be there. So nowadays, there is a paradigm shift. Initially, some 20 years back, we were using injections, aminophylines and deriphyllins to reduce the bronchoconstriction, the breathlessness. But now we have shifted to steroids and inhaled steroids, inhaled bronchodilators, which are extremely effective. Only when these methods fail do the patient require ventilator support. And one very important complication of this is carpulmonal. Carpulmonal is right heart failure because of the pressure, compression of pressure. There is a right heart failure. So the pulmonary artery that supplies into the lungs, the right ventricle is not able to pump enough blood because of the damaged lung. So the volume overload in the right ventricle, then right ventricle enlargement, right ventricle hypertrophy, causing right ventricle failure like JVP. And sometimes subtle patient, minor COPD patient can first time land into the hospital with this acute breathlessness secondary to carpulmonal. I think I'll show you a couple of X-rays. This is the right time relevant X-rays. Just give me a minute.
Wow.
Okay, look at this. Look at this. Don't look at the pathology here. Look at the shape. This is the semi-conical shape of the chest. Don't look at this pathology. That's a different story. Just look at the chest. Look at the shape of the chest here. It is semi-conical here, right? Versus this is normal shape of the chest, and now you can see the barrel shape of the chest. It's very clear here. This is the barrel shape of the chest. So the anterior posterior diameter becomes almost equal. This is a barrel shaped chest. Barrel shaped chest is one of the features of COPD, not asthma. And you can see this, the barrel shaped chest here. This is a barrel shaped chest with hyperinflated lungs. So many ribs are seen. Hyperinflated lungs, and your heart is becoming like a small tube because of the hyperinflated lungs compress the heart from the sides, making this. So one of the differential diagnosis, one of the diagnostic features on X-rays, barrel-shaped chest, widened intercostal ribs, and tubular heart are the diagnostic features of COPD, radiological features. So with this, I think we'll take up a couple of questions regarding asthma and COPD, if any. Do you have questions?
Yes. Someone was asking, isn't bronchi just specific to pneumonia and COPD?
No, I did not say it is specific to pneumonia. It is specific to bronchial asthma and COPD. Bronchi is nothing but a musical sound heard during auscultation in both asthma and COPD. It's not a feature of pneumonia. Pneumonia has different features. Next.
In which disease can we see fibrillation of lungs?
Sorry?
Fibrillation of lungs.
Huh?
Fibrosis, I think.
Fibrosis, yes. COPD. Sorry, I didn't get the question. Fibrillation.
In which disease can we see fibrillation of lung?
Fibrillation of lung. I'm sorry, what do you mean fibrillation of lung?
Fibrosis.
Maybe fibrosis. Fibrosis is one of the complications of COPD. COPD patients, once the alveoli damages, as I showed you in the figure, the fibrous tissue gets accumulated there and it makes a permanent damage. That's why COPD is a irreversible disease. Asthma is reversible. So the irreversibility is because of the fibrotic changes that occur in the patients with COPD after 10 or 15 or 20 years.
What is asthma COPD overlap syndrome?
Excellent. Asthma COPD overlap syndrome. As I told you, this is a new entity. For the last 10 years, we are hearing this word. Asthma COPD overlap syndrome. ACOS. Asthma COPD overlap syndrome. ACOS. ACOS is sometimes, though we have differentiating points between asthma and COPD, it's not that easy in many times, many patients. Some patients have the features of both asthma and COPD. Now this is a new entity that we are coming across in last 5 or 10 years, that ACOS, asthma COPD overlap syndrome, is a well-known. The treatment-wise, diagnosis-wise, everything is same. They have features suggestive of both. And remember, the bronchial asthma patient, though their bronchoconstriction is reversible initially, if you take a chronic bronchial asthma patient who's having asthma for 20, 30, 40 years, after so many years, the asthma also starts behaving like COPD. And the bronchoconstriction becomes irreversible, and they have the fibrotic changes in the lungs. They behave like COPD.
Cause of excess cough and mucus with normal X-ray and PFT.
Yeah, as I told you, bronchial asthma patient will have usually excess will be normal, and they have inflammation of the airways, excessive production of mucus, damage of the airways, mucus production is increased. So they have they have cough, they have breathlessness, they have mucus. But in bronchial asthma, as I told you, the X-ray may be absolutely normal unless there is a secondary infection or some other lung pathology. By rule, the asthma X-rays are normal.
Sir, is there a need to clinically differentiate between emphysema and chronic bronchitis?
Yes. That's again a good question. Though both are components of COPD, treatment-wise, prognosis-wise, there are little differences there. In chronic bronchitis, patients have a lot of sputum production. You may have to give the medicines which reduce the sputum. And emphysema, the sputum production is very, very minimal. And that's why we also have two other names. In COPD with predominant chronic bronchitis, we call it as blue bloaters. And COPD patients with predominant emphysema, we'll call them as pink puffers. Pink puffers and blue bloaters. So they don't occur in isolation. They're most of them they coexist. They're overlap syndromes.
Yes.
Any more questions from the house here?
So the definitive diagnostic test for COPD.
COPD, again, there are multiple: history, examination, pulmonary function test, X-ray. That's all. These are the diagnostics. You have to use all these things to diagnose. Basically, if you take proper history and examination, examine the patient, you can more or less come to a near diagnosis basing on these things. And then you take an X-ray, as I told you, barrel shape.